Welcome to the Pink Pineapple Podcast, where we peel back femtech and take a bite out of more than just the juicy bits.
I'm Claudia, and I'm Emma's partner in Pineapple for this adventure.
And I'm Emma. Together, we're exploring women's health across the full timeline, from first periods to menopause and everything in between.
Each week, we'll dive into the stories, science, and software shaping the future of women's health. From hormones to hardware, fertility to femtech founders.
Think of us as your slightly nosy best friends who just happen to be doctors with a healthy curiosity for innovation.
We'll be chatting to clinicians, creators, and change makers. And yes, asking the questions you actually want answered.
So whether you're out for a walk, cooking dinner, or hiding from your to-do list, join us as we get curious, clinical, and occasionally controversial.
This is the Pink Pineapple Podcast,
where women's health meets what's next. Hello, everyone, and welcome to another episode of the Pink Pineapple Podcast. And today we have Dr. Tom Chambers with us. He's a somnologist and the co-founder of Theta Sleep. 10 points and a gold star if you know what a somnologist is. Claudia, I don't think you've got a somnologist with you, but I think you've got something else. What's under
No,
the
I
desk?
don't have. There's not a somnologist, but this is today's pineapple. She's got a sleeping mask on, as you can see, and she's got nasal strips, which are completely useless for the condition that we will be talking about today. But a lot of people do begin here, I would say, before they go and speak to anyone and get any help. So here she is, sleeping mask and nasal strips.
Lovely. Well done, Claudia. You could have a gold star as well. So, Tom, welcome to the podcast. So for our listeners who haven't come across Theta Sleep before, could you kind of give us a brief rundown of what it is that you do?
Yeah, of course. Thank you very much for having me on. And that is a great pineapple. Love the eye mask, certainly. One of my favorite sleep things in eye masks is something that actually does have some evidence, in contrast perhaps to the nasal strips, for improving someone's sleep. So yeah, what we do with Theta Sleep is our whole vision is, how do you take sleep medicine care pathways, take them out of hospitals and deliver them in patients' homes, where they should be, given that's the place where we are all sleeping. Everything we can across the clinical pathways, the clinical workforce, the innovations across the care pathway, and how do you bring those into patients' homes to manage the, more than 10 million people living with underdiagnosed or poorly managed sleep disorders in the UK. And we do this through our secure proprietary in-house digital platform for patients and clinicians. So it's a patient-facing digital app where they get sleep education, guidance through the sleep medicine journey, can ask questions, etc. That talks to our clinician-facing electronic health record that streamlines the whole care pathway for clinicians, and then the relationships with various suppliers to get the medical device equipment into patients' homes that they need. So the right diagnostics, the right treatment, etc.
It sounds super interesting. I know kind of that we've talked kind of briefly before we came on to the podcast about Theta Sleep being tech enabled. Could you kind of expand on that a little bit and about how that tech enabled sleep clinic is different to, for example, what someone might describe as a digital clinic or an app-based clinic?
Yeah, absolutely. So I think for me, that whole sort of tech enabled care model is, how do you take all of the tech innovations across a care pathway and get them into the hands of patients? So it's everything across the whole care pathway. So it is the novel diagnostic devices that are out there for sleep apnea at the moment, which are in a nice guidance at the end of 2024. How do you take all those devices and give them to the right patients? How do you use the latest innovations across digital health platforms, across treatment, across following up patients whilst they're on their treatment? So for example, standard treatment for sleep apnea is a CPAP device, which we might get into later. How do you take the data off that device? How do we bring that into our platform to be able to monitor patients, dynamically intervene if they are struggling with adherence to therapy? How do you use all the innovations that are out there and actually deliver them to the patients? Because I think the problem for most traditional sleep clinics and most traditional NHS sleep clinics that I've worked in is they were built, 15, 20 years ago when the demands were very different to what they are now. They were a traditional hospital-based system. Small number of patients would come in, they'd pick up the kit, they might have the face-to-face appointment, they'd go home with it. Obviously then just can't manage at scale. So I think a lot of the tech-enabled care model is, how do you do these things at scale? How do you meet the growing demands that are on all healthcare systems, but particularly in sleep? So sleep studies, the diagnostic for sleep apnea is grown by more than 102% in the last 3 years, the fastest growing diagnostic test that we undertake in the NHS. And just at the scale required, you need to use the innovations across the care pathway. So for me, it's how do you get those scalable innovations and use them sort of safely as well, use them correctly? How do they fit into clinical pathways? You can't just blanket use some of these new tools and new devices. It's about picking the right ones for the right patients.
And you mentioned sleep apnea. So for those that don't know what sleep apnea is exactly, could you explain to us what it is?
Of course, yeah. Sleep apnea is a remarkably common condition. Affects, we think, 1 in 4 adults in the UK. It's probably nearly 11 million people in the UK who have sleep apnea. 85 to 90% don't know about it yet, haven't been diagnosed. And it is this condition that, simply put, is where you're stopping breathing during your sleep. It sounds very frightening, and in lots of places it can be quite frightening when you look at someone's sleep study and see quite how bad their sleep apnea is and how often they're stopping breathing and for quite how long and the impacts it has. So obstructive sleep apnea is by far and away the most common type of sleep apnea, and what causes that is when you drift off to sleep and you're going through your sleep stages, all of the muscles in your neck kind of relax and soften, and what that does is as the airway closes off a little bit, you get vibration of air, and that's what snoring is. It's simply the kind of vibrations of air going through the airway. And then as that gets more severe and closes off more and more, you get a significant reduction in the airflow or even a complete cessation in the airflow, which is what defines an apnea. And some people are having apneas, once a minute, twice a minute, stopping breathing hundreds of times per hour. And as you can imagine, that then severely disrupts your sleep. So you're not getting that nice, refreshing, deep sleep. You're getting a reduction in across all sleep stages, but also you're getting low oxygen levels, cardiovascular impact that comes off the back of that, reduced quality of life, increased risk of cardiovascular disease, diabetes, dementia, anxiety, depression, sort of you name it. Sadly, sleep apnea is linked to it, and most people are currently undiagnosed with them.
And often when we think about sleep apnea, we have this image of a man snoring really loudly, an older man snoring really loudly in his bed. But is that the case, or does it also impact women, and how much?
Yeah, it's a really big problem in sleep medicine. The image that we have of this older, overweight, middle-aged white man essentially is the archetypal patient, and it's also far too many things are the archetypal patient who all of the research has been done on, and all of the ways that we diagnose are based on that, the way that we screen is based on that, the way that we treat is based on that person. And increasingly we are aware that it is not a condition of older, overweight, middle-aged men. It's not a condition. The first thing to say is it's not a condition of obesity, particularly. If you look at data on people with sleep apnea, it's about only about 35% are obese who have sleep apnea. Most people, the vast majority of people with sleep apnea are not obese, and it does not. It does impact. There is a higher prevalence in men, but not a significantly higher prevalence, especially after the menopause in particular, where some of the protective effects of estrogen and progesterone are lost and the prevalence kind of levels out. And there's a huge problem in the community that you will often have women who are perimenopausal or have just gone through the menopause and have got symptoms of fatigue, tiredness, those sleep apnea symptoms that are being misdiagnosed often as symptoms of the menopause. And actually you do a sleep study, you find out they've got sleep apnea, you start them on CPAP, and they have that life-changing event where they're no longer getting the brain fog and the fatigue, etc. Because the other problem is the typical symptoms that we think of in sleep apnea are all based around men as well, the loud snoring, the sleepiness, whereas women are more likely to have insomnia, kind of cognitive impacts from their sleep apnea, brain fog, fatigue, much more subtle symptoms. And most of the screening questionnaires, most of the education we give to GPs or other healthcare professionals is about the snoring and sleepiness, and that is often not how it presents in women.
I think that's a really interesting segue into sleep in general. And does it differ between the sexes? Does sleep differ between men and women?
Yeah, absolutely. I think there's lots of different ways you could potentially answer that question in terms of how sleep is different. I mean, sleep is a wonderful, unique experience for everyone. Everyone's sleep is different, but across the sexes, certainly there's differences in the physiology. There's difference is in the clinical presentations and clinical disorders that are more common. And obviously there's then the differences across the lifespan, which generally impact women a lot more. From a kind of pure physiology perspective, we always think about sleep in terms of both the kind of action of sleep, or the experience of being asleep, and then also our circadian rhythms. So sleep being that, those sleep stages, the sleep cycles that you go through with the light sleep, deeper sleep, slow wave sleep, really deep sleep, and REM sleep. And then circadian rhythms being the 24-hour rhythms that exist in every single cell in our body, but are often, as you can imagine, sleep is sort of the archetypal thing that you do in the middle of the night and not in the middle of the day. And both of those things are different in men versus women. So women have more slow wave sleep than men in general. Men have a bit more stage 1 light sleep than women. Women respond differently to sleep deprivation. They have a different rebound response when they're sleep deprived. They also have a bit of a shorter circadian rhythm in general. So more likely as a woman to be an early bird than a night owl a little bit, and also have longer periods of sleep. So we do find that women on average have a greater sleep need than men do. And they're all on a spectrum, everyone's on a normal distribution, and no two people will be the same, but there are kind of fundamental physiologic difference between the sexes as well.
And I guess there's a difference that happens, as you said, over the course of somebody's lifetime as well. So I suppose it's probably different during maybe puberty, pregnancy, postpartum, perimenopause, menopause.
Yeah, absolutely. Across all of those life stages, sleep changes. In puberty, one of the biggest things actually for both men and women is that we often get a later circadian phase. So, the lazy teenager narrative, which again is one of these tropes in sleep medicine that is completely misguided. We get a later circadian phase. We want to go to bed later and get up later in our late teens and early 20s. And then pregnancy is one of the big life stages for sleep impact. And across each trimester, there are differing impacts in sleep. Some of them are hormone driven. Others are just physical driven, the discomfort of having a child that you're growing and all the impact that has on your sleep, and being able to sleep well and have disrupted sleep. There's some theory that maybe the disrupted sleep in pregnancy is some sort of protective thing to prepare you for when you've got a newborn. I have heard that said and not been debunked.
That's how people, sorry to would try and make me feel better. That's what everybody would say to me. It's just preparing you, Claudia. This every 3 hours, wake up to go do a wee. It's preparation.
Yeah. And one of the, you mentioned kind of waking up multiple times overnight to go for a wee. One of the things I will touch on in pregnancy, again, coming from a sleep apnea background, is it's a massive unrecognized problem is sleep apnea in pregnancy. The risk of sleep apnea goes up because you get airway swelling, increased edema everywhere, increased risk of sleep disordered breathing. And we know that people with sleep apnea, undiagnosed and untreated sleep apnea, have worse pregnancy outcomes, higher risk of pregnancy-related hypertension, higher risk of preeclampsia, higher risk of needing an emergency cesarean. And it could well be a great time to screen, diagnose, and get people treated at the point of preconception. Well, not preconception counseling, but 8 or 12-week appointment, for example. The problem is there's not enough good data on how to do it because of the issues that we all have in the NHS with wait lists and wait times. You can't turn around a sleep service generally quick enough that people will be able to go looking for it at the right time and try and make an intervention. And it's something we're working on at the moment in a couple of places about a pathway to identify, screen, diagnose and treat women in early stages of pregnancy to try and improve those outcomes.
That could be so impactful, couldn't it? That could be so impactful. And you mentioned data. I'm taking us just on a slight tangent here, but you will be gathering a lot of data. And I presume because you're very much sort of, tech enabled, you've probably done a lot of thinking around this data and how you are storing it and the fact that you'll be able to use it and to research it. So I think there's a lot of potential, if I'm guessing correctly, in Theta Sleep really getting down to the bottom of pulling some really good data out that we've maybe never even seen before.
Yeah, absolutely. That's one of the exciting things about building the whole thing from the ground up and going, how do we want our database to look? We build our patient database to be used how we will want to use it for research, for service development, for audit, etc., to make sure we're delivering that kind of best quality of care. And the insights that we will hopefully be able to gain in the future by having a big data set of the whole care pathway will hopefully be great. It's longitudinal, almost cohort study within itself, obviously with all the correct data management and consents, etc., to do all these things. But yeah, it's something I am very, very excited about in the future.
Do you think, Tom, that we would, look more long-term basis, we'd be able to pick up diseases, kind of comorbidities just from seeing some of the changes in sleep data then over time, or go who to screen for things purely because of the data that we're getting from sleep?
Yeah, absolutely. There was actually an incredibly interesting paper that I can't remember the exact name, but I'm sure we can find it and put it in show notes search for this afterwards. Recently published, that I saw actually was reshared on LinkedIn by Eric Topol on a big data set out of the States, which is taking PSG data, so polysomnography data, which is the sleep study data for the kind of really old school sleep studies that they still do a lot of in the States. So PSG is full sleep study, EEG dots on the head to measure brain waves, bands around the chest, bands around the abdomen, oximeter on the finger, ECG dots, full works, wires everywhere. And you can imagine the data that comes out of that. But this study was looking at how single night PSG data can predict a vast range of disorders, long-term morbidity, mortality, etc., just from sleep data. And I do think that is an area that will become increasingly exciting. And it's where wearables, if they get it right, can go. I would certainly say they're not really getting it right at the moment, but it is the kind of place where it could be. The data that's coming off some of the longitudinal wearables around sleep is phenomenal and could genuinely make a difference to how we approach sleep medicine in the future.
Yeah, and that's the question about wearables, isn't it? Are they getting it right, or are they getting it very wrong at the moment?
Yes, it is a complex question, certainly. I think they are probably causing more harm than good at the moment. I think one of the biggest things, sort of real soapbox stuff, but sleep scores from any wearable are largely complete nonsense. They are, they're made up because we don't know what good sleep looks like. Even if you're looking in a lab at someone's sleep data over the course of the night and you can stage their sleep, good sleep for each of us will look different because one of us will need more N2 sleep than N3 sleep. One of us will need more REM sleep. And you can't know for an individual what good sleep is. It's all about how you feel the next day and various other bits and pieces. But I think because people love data, and they love seeing a score, that's why the wearables have all given a sleep score, and they are just made up. And they make people sleep worse. There is a phenomenon called orthosomnia, which is trying to get good sleep. Ortho means good. I didn't know that until I found this. So I wondered how it related to orthopedics, but it's, orthosomnia, the pursuit of perfect sleep, is causing insomnia and people trying to get their maximum sleep score, which is complete nonsense. That said, there are some really, really good stuff out there on wearables, particularly in sleep apnea. Longitudinal monitoring will give us insights that we've never had before, because you can look at how sleep apnea or any sleep problem varies on a nightly basis, which generally we don't do. It's kind of one night sleep study. So some of the kind of, they're more nearables than wearables, but under mattress sensors, there's a phenomenal amount of data coming out of a few research groups in the States and in Australia about longitudinal data on sleep apnea, how it changes night to night, impact of the weekend, how those things change, resistant hypertension, cardiovascular disease, etc. So when used well, it could be amazing and hopefully will do. But I think the vast majority is still not being used very well.
Ask you, Tom, a question about dreaming, because I
Ooh.
feel that this is something like in our household, for example, my husband is always telling me about all these amazing dreams that he has. And I don't feel like I dream very much, apart from when I'm pregnant, when I seem to dream all the time and have a lot more vivid dreams. And I don't know, I've been told or I've heard that it's to do with the progesterone in pregnancy potentially having an impact on dreams. But is there a reason why some people dream more than others? And I suppose the other thing is, are there outcomes associated with those who dream and those who don't. And the reason I asked that as well is because I was listening to a podcast and they were talking about Parkinson's, and they were
Mhm.
actually talking about one of the most subtle, or there's less awareness around the fact that people can have sleep disorders as a sign of Parkinson's. So yeah, I would love to hear a bit more about dreaming that I can take back to my husband and explain why I don't dream.
Yeah, so they're two very, very interesting questions. I might have to answer them separately because the Parkinson's sleep link and Parkinson's dreaming link is a really important sort of separate clinical phenomenon. But in terms of the science of dreaming and the art of dreaming, etc., it's one of these that obviously has fascinated everyone for years, and we still, I don't know, are we ever really going to fully understand them? Probably not. We think everyone dreams for most of the time that they are asleep. There's a bit of a kind of thought that REM sleep is the only time that we dream. It's not true. REM sleep, we often have more vivid dreams. We're more likely to remember our dreams during REM, and you're more likely to recall them the next day in REM sleep. But we think we are dreaming for a significant proportion of all of the other times, but they're probably a little bit more boring, a little bit more monotonous, and they're in deeper stages of sleep as well. So that means REM sleep is often happening just sort of the period between as you're about to wake up, which is why you're more likely to remember those. Some people just remember things better than others in their dreams, and you can train yourself to, if you really want to learn and record your dreams, if you start trying to create a dream diary and wake up and think, what did I dream about, you will get better at it, because you get into this really interesting, like, what is consciousness, what is dreaming, what is sleep. You can get into these sort of deep philosophical conversations which kind of anchor around the fact that sleep is not a binary on off thing. This idea that when you fall asleep you're off and when you're awake you're on is just not the case. Different parts of your brain are asleep at different times, which is why you remember some things, it's why you don't remember other things. It's why when you're going on holiday and you need to set an alarm at 3 a.m, you're awake at 2:55, because it's not an on-off switch. You are more aware of your surroundings, etc. Progesterone sleep is an interesting question. I don't know about any link between progesterone and dreaming. I will have to go away and do my own homework. A lot of the stuff on looking at sex hormones and sleep, the kind of preclinical data and the clinical data often don't quite match up. It's one of those, many areas that sort of don't exactly know. That we know there's impact, but kind of don't know the full ins and outs of it. Oh, the Parkinson's. Yeah, on the Parkinson's side as well. The link there, and it's a really important and interesting one. So there's a sleep disorder, it's not that uncommon, but called REM behavior disorder, which is this disorder where people typically act out their dreams. And there is some evidence and a theory that actually REM behavior disorder is simply prodromal for some neurodegenerative disorders. So like Parkinson's or other kind of Lewy body related disorders, that you can have REM behavior disorder years before you go on and develop Parkinson's. But the data suggests that if you follow up people with REM behavior disorder, where they're acting out their dreams in REM, they are overwhelmingly likely to go on and develop Parkinson's or something similar later down the line. So it is increasingly being seen as not even a risk factor, but kind of an early symptom, which is an interesting one to manage when you identify it with patients, because having that communication when there's still quite a lot of unknowns about what it means is quite difficult, but a kind of increasingly
Yeah.
important area.
I love the way you said that about it not being binary, because I do this weird thing where if I don't like a dream, I don't like where it's going, I don't like where it's heading, sometimes I'll wake up and I'll go back and I'll redo it so that it ends the way that I want it to. So definitely, I totally agree with you. It's not like an on-off thing at all.
Yeah, no, not at all. And
Yeah.
that sort of lucid dreaming almost, again, is something that I think you can teach yourself to do to a certain extent. I remember as a kid, I used to have these recurring dreams where I'd almost they were sort of semi nightmares, and to get out of them, I always had to complete some challenge in the dream. If it didn't happen, if it did complete it, I'd then wake up, and if it didn't, you'd still be stuck in there. So yeah, it is fascinating stuff. But dream research is brutal. So dream research, you've got people in laboratories, they stick all the EEGs on, and then they wait till someone's in that right stage of sleep, and then they immediately wake them up and ask, what was going on. So that's how you go. Are you dreaming more in REM sleep or in deep sleep? You pull someone out of deep slow wave sleep. It is miserable. It's interesting to talk about. I don't think it would be that much fun to be a research participant though.
No, I wonder if one day we'll be able to actually pull them out visually. Like, I wonder if you'll ever be able to translate what somebody's actually experiencing into something visual. That would be quite amazing, but also quite terrifying as well.
Yes, agreed.
So we've kind of touched on sleep apnea when it comes to sleep issues with women. Are there any other common sleep problems that you see in women in your clinic?
Yeah, absolutely. So typically, the sleep disorders that are more common in women than men are insomnia is more common in women than it is in men, and movement disorders like restless leg syndrome or periodic limb movements in sleep is more common in women and very common during pregnancy. Restless legs, certainly. Most of the patients we see in our clinic are patients who have been referred for sleep apnea. We see the full spectrum of sleep disorders, but it is largely sleep apnea. And the big thing there is not seeing enough referrals for women with potential sleep apnea. But yeah, it does seem that insomnia is more common, which might be to do with this differences in circadian rhythm that we were talking about before, that women's sleep periods might be slightly circadian misaligned, which might increase the risk of insomnia. Restless legs is more likely because often it's an iron deficiency problem. Restless legs, we think it's a brain iron deficiency rather than a sort of total body iron deficiency, but that is why they're linked, more commonly in women and more commonly during pregnancy because of the kind of anemia link there.
Yeah, that's a really good reminder actually for people to check iron levels with restless legs because I'm not sure that that's kind of universally done, particularly I suppose in older patients. But anemia, again, for various reasons, can be obviously very prevalent in older populations as well, can't it? Either dietary or as a result of a chronic disease or something more sinister sometimes underlying. So yeah, it's definitely a really good point for us to have a think about there. With regards to insomnia, I'd be really interested to know what your definition of insomnia is, because I think that, for example, in GP land, I would say we get a lot of people who come in and they say, I can't get to sleep, I can't get to sleep. And often there's that could be situational or sometimes environmental. So it could be, for example, that there's something that they're very worried about, or it could be that there's potentially, noise pollution, etc., or light pollution that's causing the problem. But there are other people who will come in and say that they might get to sleep, but then they wake up multiple times in the night and they can't get back to sleep. So from your somnologist definition, how would you describe or define insomnia?
Yeah, absolutely. So yes, you hit on a tricky, important clinical problem there about the difference between insomnia symptoms and then insomnia disorder, kind of officially diagnosed insomnia disorder. And the definition, as per the International Classification on Sleep Disorders for chronic insomnia, is that you have to have a difficulty with either getting to sleep, staying asleep, or waking up too early. That difficulty happens more than 3 days a week, that it's happened for more than 3 months a year, and that it is impacting your life in a significant way, impacting work, relationships, whatever that may be. That's the kind of label of chronic insomnia disorder, which, sometimes is useful, but realistically kind of putting people in boxes just because we like to add labels is not necessarily always clinically that valuable. The point that you make there about people who come in because they can't sleep and it is a non-sleep, non-clinical sleep related problem, but the noise pollution or the pet that they've got that's keeping them awake all night, or young child or whatever that is, that maybe is a really, really important one. Insomnia should not be diagnosed if there is a more likely explanation of getting off to sleep because you've got a very noisy neighbor or because you've got light streaming through the windows, all of those things. And actually, there's a significant proportion of sleep problems that we could do a better job with by simple things, like your lovely pineapple in the eye mask. That helps a lot of people. But the insomnia disorder and insomnia symptoms, the other problem is we know that people with insomnia symptoms, so be that getting off to sleep or staying awake overnight, whatever that is, are much more likely to go on to develop chronic insomnia disorder. So we should be intervening where possible, as early as possible in someone with insomnia symptoms to stop it progressing to chronic insomnia disorder. I think there's a huge amount that can be done just in terms of public health education on sleep health. Use the word sleep hygiene a lot and used to use it a lot more, which can be a little bit of an unhelpful term. It can be a bit judgmental in a way. You're sort of talking about the people with noise pollution and bright lights, etc. And you're saying, oh, improve your sleep hygiene and you'll get better is not very useful when the light streaming in they can't do anything about, or the noise next door they can't do anything about. But I think any insomnia symptom complaint that you've got is worth trying to understand it better. And if you need kind of treatment for that and solution for that, it's worth seeking treatment. There is hopefully coming soon. There was at the back end of last year, there was a nice consultation on digital therapeutics for insomnia. So there are a few available digital therapeutics for insomnia which deliver cognitive behavioral therapy for insomnia, CBTI, via a digital platform. They are medical devices, etc., etc. That should be coming very soon. The final decision on nice guidance there, and it could be that actually people will be able to self-refer for things like Sleepio in the not too distant future in the UK, which is great. You can get it in Scotland at the moment. You can't get it in England, but hopefully that is changing.
And how, Tom, does the menopause fit in with this? I've certainly seen a lot of women who are perimenopausal, menopausal, coming in with sleep issues, particularly struggling to stay asleep.
Yeah, absolutely. And I think it can impact every aspect of sleep. I think the various symptoms in the menopause, much like we were saying with pregnancy, there are hormone related issues and there are more physical related, hot flushes that are happening overnight will often drive insomnia and may cause people to wake up. And then it's those broken periods of sleep where you end up, we talk often a lot in insomnia about the bed sleep connection. So the bed should be this place where all you're doing in your bed is sleeping. So if you're spending long periods of time awake in your bed or doing other things in your bed, that reduces that bed sleep connection. And there are so many things during perimenopause or menopause that can create that. Fortunately, we are better at, identifying, thinking about sleep disorders during the menopause. I think in the last year or so, there's a good guideline, which again, hopefully we can share from the British Menopause Society on how to identify and manage sleep disorders in the menopause. Largely speaking, it's the same as we identify and manage sleep disorders in the general populations. Have a low threshold to try and go looking, because most people with sleep disorders are undiagnosed, and treat them in the same way. CBT for insomnia is the first line, which currently is very hard to access because most of it is person delivered or face to face, which will hopefully change, as I said. The big thing I will certainly want to add into this is consider whether there is an element of undiagnosed sleep disorder breathing driving this. Your risk of sleep apnea goes up significantly during the menopause, and ongoing fatigue, sleepiness symptoms, broken sleep, all of these insomnia symptoms can cross over with sleep apnea, and looking for it and getting it, referral, diagnosed, treated can be life change for people who are really, really struggling with their sleep at that time.
And so just to touch on your own career, Tom, you have come into sleep medicine from an anaesthetics background. How have you found making that transition?
Yeah, so now spend my life doing sleep medicine, and I'm currently out of my anaesthetics training. I've still got a training number in anaesthetics, but I'm on a year and a bit out for everything we're doing with Theta Sleep. I came into it because I happened to have a respiratory fellow job that was in sleep, and then I knew I wanted to do anaesthetics, so did another fellow year doing perioperative sleep medicine stuff, so trying to screen, diagnose, treat sleep apnea in the perioperative period, because sleep apnea is a massive risk factor for airway complications during surgery, etc. So that was my routine, and then I just found that loved sleep and wanted to do more of it. Essentially on both of them, like, I'm definitely just a bit of a physiology loser, physiology geek about it. Anesthetics, I think, is very useful for that, and sleep is, fascinating from a physiology perspective. So that's probably the crossover there. And I think the sleep side was just, it was interesting. It's really difficult to get the right training in this country on it, which is why I then went and did a master's in it, and have done the somnologist qualification that you can get in Europe, but you can't get in the UK, which is, generally a big problem in sleep in the UK, is there's not enough kind of training pathways. The other thing to say on a sleep apnea perspective, the some anaesthetists will tell you that, sleep apnea is an airway problem. It's not a respiratory problem. So respiratory people shouldn't be doing sleep apnea. It should be anaesthetists. So there's lots of crossover.
And where do you see things going next with Theta Sleep? Have you got any more kind of plans in the pipeline? Are you thinking about expanding the service, or is it going to be evolving in any way?
Yeah, absolutely. So we provide our tech-enabled sleep medicine service to patients anywhere across the UK. Mixture of NHS and private patients. We have private patients kind of coming in from wherever or from various referral partners, etc. We have a group of NHS patients that we deliver the sleep apnea care pathway for up in Yorkshire, and we are in conversation with a number of different providers, right down from GPs up to trusts, up to ICB level, about how to do sleep medicine in a better way, how to do it tech enabled, how to do it in homes, out of hospitals, all of that in line with the 10-year health plan. So my hope for this year coming is that we launch another NHS sleep service in a new area, showing how to, essentially espousing the virtues of this tech-enabled at-home care model in this area that is, as I said, one of the fastest growing areas that we're dealing with in the NHS at the moment.
I love it. That is absolutely super. So good luck, Tom. Best of luck. We'll be cheering you on as well. We're going to be watching closely.
I'm going to say, Tom, if you could give us like one closing message for any women that are listening to this. If there's one thing that they can do tonight to try and improve their sleep, what would it be?
I'm going to give a very boring answer to this, I think, sadly, which most sleep improvement things are quite boring, sadly, which is go to bed at the same time as you went to bed last night, or perhaps more importantly, get up at the same time. So sleep regularity is probably more important than sleep duration, we think, for morbidity and mortality and health in general. Getting that consistent circadian phase where you're waking up at the same time and going to bed at the same time every day is probably the best thing you could do. It's a lot easier said than done with other things that happen in life, but consistency is probably the best thing you can do for your sleep.
So not chuck your partner out or chuck the dog out.
Well, I mean, chuck the dog out can certainly sometimes be the solution for some people.
Oh, thank you so much for coming on, Tom. It's been really interesting. I've particularly enjoyed kind of learning more about the physiology of sleep, which is something that we don't cover extensively when we're training. So yeah, it's been a real pleasure.
Thank you very much for having me. It's been really fun chatting about this.
Thank you. Bye.
Yeah. Bye, Tom.
Bye.
Thanks for being here. We love having you with us on this journey through women's health and innovation.
Follow us on Instagram at the Pink Pineapple Podcast for clips, conversations, and the latest in women's health and femtech.
We'll see you next week. Same pineapple, new topic. Everything we talk about on the Pink Pineapple Podcast is here to inform and inspire, but it's not a substitute for professional medical advice. If you're worried about your health, please reach out to your GP or healthcare provider.